let's get right into this rapid explainer of high-yield endocrine tumors, pediatric endocrine emergencies, and those tricky endocrine pharmacologic traps tested heavily on Step 2 CK. On the agenda today, we're covering endocrine neoplasia syndromes, pancreatic neuroendocrine tumors, pediatric adrenal disorders, neonatal thyroid disease, and finally, endocrine medication traps. We'll be using strict next best step logic throughout. Section 1. Endocrine neoplasia syndromes. We'll start with the adult genetic tumor syndromes, specifically the multiple endocrine neoplasias. For multiple endocrine neoplasia type 1, or MEN1, just remember the 3 Ps. First, you've got pituitary adenomas. These typically secrete prolactin, growth hormone, or ACTH. Second is primary hyperparathyroidism, which shows up in over 90% of these patients due to multiple adenomas or hyperplasia. And the third P stands for pancreatic or gastrointestinal neuroendocrine tumors.
Now, contrast MEN1's 3 Ps against MEN2. When you see MEN2, the clinical trigger you should immediately think of is the RET gene mutation. That should automatically prompt you to suspect and screen for medullary thyroid carcinoma and pheochromocytoma.
Speaking of pheochromocytoma, sure, you know the classic triad: episodic headache, sweating, and tachycardia. But on the exam, you need to test for it if you see resistant hypertension or hypertension paired with unexplained hyperglycemia. This is especially true if the patient has a familial syndrome like MN2, NF1, or von Hippel-Lindau. For the diagnostic pathway, you have to follow a strict next best step sequence. Always check biochemical markers first. That means 24-hour urine fractionated metanephrines and catecholamines, or plasma fractionated metanephrines. Do not jump straight to imaging. You only order that confirmatory abdominal CT or MRI after the labs come back elevated, usually 2 to 3 times the upper limit of normal. Once you've confirmed a pheochromocytoma, the management logic is absolutely critical. You must administer preoperative alpha blockade before you give a beta blocker or attempt surgical resection. If you block beta receptors first, you get unopposed alpha adrenergic stimulation, which can trigger a fatal hypertensive crisis. Alpha before beta, always. Section 2, pancreatic neuroendocrine tumors. Let's look at the diagnostic patterns for these. You need to differentiate islet cell tumors by their specific hormone excess. Insulinoma presents with fasting hypoglycemia and neuroglycopenic symptoms. You'll see high insulin, high C-peptide, high proinsulin, and importantly, a negative sulfonylurea screen. VIPoma, on the other hand, gives you massive secretory watery diarrhea, hypokalemia, and achlorhydria. Then there's glucagonoma, which causes weight loss, new-onset diabetes, anemia, venous thrombosis, and that classic skin finding, necrolytic migratory erythema. Next up is gastronoma, which causes Zollinger-Ellison syndrome. The test pattern here is a patient with multiple refractory peptic ulcers, especially ulcers located beyond the duodenal bulb, along with thickened gastric folds and chronic diarrhea. For the workup, you want to test fasting serum gastrin while the patient is off PPIs. If the level is intermediate, the next best step is a secretin stimulation test. Once confirmed, you localize it using CT, MRI, and somatostatin receptor imaging. Section 3, pediatric adrenal disorders. Here we'll focus on neural crest and adrenal cortex pathology. Let's talk about neuroblastoma. You'll typically see this in children under 2 years old. It originates from neural crest tissue, usually in the adrenal medulla or sympathetic chain. Clinical clues are a huge giveaway here: an abdominal mass, periorbital ecchymosis, also known as raccooneyes, from orbital metastases, opsoclonus myoclonus syndrome, or even spinal cord compression if it's a dumbbell tumor. Diagnostics will show elevated catecholamine metabolites, small round blue cells on histology, and NMYC gene amplification. Next, you need to compare classic and non-classic congenital adrenal hyperplasia, or CAH. Both are primarily caused by 21-hydroxylase deficiency. Classic CAH presents very early with severe mineralocorticoid defects and, in girls, ambiguous genitalia. Non-classic CAH, however, presents much later in life with normal corticoids but elevated androgens. A massive red flag for classic CAH: boys might look completely normal at birth, but then they develop a life-threatening salt-wasting crisis around 1 to 2 weeks of age. They'll present with hypotension, dehydration, vomiting, hyponatremia, hyperkalemia, hypoglycemia, and shock. Labs will show high 17-hydroxyprogesterone. You have to treat this immediately with both glucocorticoids and mineralocorticoids. In contrast, patients with non-classic CAH present later with signs of early puberty, early pubic hair, severe acne, hirsutism, oligomenorrhea, and an advanced bone age. Because their mineralocorticoid production is actually intact, you treat them with hydrocortisone alone. Section 4, neonatal thyroid disease. We'll look at maternal antibody transfer versus developmental dysgenesis. Let's contrast neonatal thyrotoxicosis with congenital hypothyroidism. Neonatal thyrotoxicosis happens because maternal TSH receptor antibodies cross the placenta. It causes warm, moist skin, tachycardia, irritability, and poor weight gain in the newborn. The key here is that it resolves on its own as those maternal antibodies clear out. You just treat symptomatically with methimazole and a beta blocker if needed. Congenital hypothyroidism, however, has a much more delayed clinical timeline. Infants with congenital hypothyroidism are often completely asymptomatic at birth. That is why newborn screening is absolutely critical. Without treatment, they'll develop lethargy, macroglossia, a puffy face, and umbilical hernia, and prolonged jaundice. If the newborn screen shows high TSH and low free T4, the next best step is to start levothyroxine immediately to prevent permanent neurocognitive injury.
Section 5, endocrine medication traps. Let's hit the high-yield pharmacologic side effects and metabolic decompensation syndromes. Here is a classic step 2 trap. If a patient taking propylthiouracil or methimazole develops a sudden fever and sore throat, you have to suspect agranulocytosis. The next best step is to stop the medication immediately and check a white blood cell count. Also, keep in mind that common things like iron, calcium, cholestyramine, sucralfate, and PPIs can drastically reduce the absorption of levothyroxine.
Next is milk alkali syndrome. This is defined by a specific triad: hypercalcemia, metabolic alkalosis, and acute kidney injury, alongside a suppressed PTH. It happens when a patient ingests excessive amounts of calcium and absorbable alkali, like over-the-counter calcium carbonate antacids. The treatment? Stop the offending agent and give intravenous isotonic saline.
Our last concept is hypoglycemia-associated autonomic failure, or HAAF. This happens when a patient with long-standing diabetes experiences recurrent bouts of hypoglycemia, which literally blunts their physiological response. It strips the patient of their neurogenic warning symptoms, like tremors, arousal, and sweating. This drastically increases their risk for severe neuroglycopenic events, like abruptly losing consciousness.
The underlying mechanism of HIAF is a reduced epinephrine surge when blood glucose drops. Without that catecholamine release, the patient doesn't get the behavioral cue to eat, and hepatic glucose production isn't stimulated. To manage this severe risk, your next best step is to carefully reduce their insulin dosing and adopt less stringent, more relaxed glycemic targets.